talks today are actually a little bit different than our previous programs. As many of you know who have listened to my colleagues and I lecture at these symposiums, we tend to focus on the science and the theory behind what we do. And that science is rapidly expanding and changing all the time. However, today, rather than going over the science and background and the data, we're actually going to be focusing more on applying that information to patients with MS in specific situations. So this is a more practical discussion. Our goal is actually to emphasize to you how important it is to actually take a holistic, global, or integrative approach, whichever buzzword you like to use, to the management of MS. And when we use that term, we actually use it based on scientific evidence that that is an approach that actually improves outcomes. And you're going to hear about that this morning from the various speakers. So the first thing is, we all know what MS is. We know that it's a very common disease. We know that for young women, it's the leading cause of fixed neurological disability in the United States. Because we know MS is a common and an important disease in the United States as well as in most of the world. And in fact, in developing nations, the importance of MS is beginning to emerge as one of the challenges that they're going to face, just like we do. So, some issues about the treatment of multiple sclerosis. If you want to have the best outcomes, then you do need to take a comprehensive approach. I'm going to talk a little bit about why you have to think about diet, why you have to think about exercise, some evidence I'm going to present for the first time on an active lifestyle and the benefits from that. And then you're going to hear from my colleagues about other therapies that are appropriate to be used in MS in certain situations. And then I'm going to focus primarily on what we call the disease-modifying therapies. These are therapies that try to inhibit the immune attack on the nervous system. And I would like to emphasize that the treatment of MS is quite complicated, and in fact, you cannot count on the healthcare system to cover all these bases for yourself. The healthcare system in the United States is relatively fragmented, and it makes it hard for healthcare providers to know whether you're actually receiving a global or comprehensive approach to management of your MS. So the more that you know about it, the more that you can then prod your healthcare providers to help you with this. So first thing is the effect of comorbidities of multiple sclerosis. Comorbidities are other health problems. And this is where diet comes in to be so important. If you develop other diet-related health problems, just simply being overweight, and particularly obesity, hypertension, diabetes, that increases substantially the odds that you're going to have disability due to MS. And what you can see here, if you develop hypertension or heart disease, that increases your risk of having moderate versus mild MS by a factor of 1.5. That means that's a 50% increase in your risk of having disability just because of that interaction. And that's also true for just being obese. That can increase your risk by about a factor of 40%. So because of this interaction of the brain with the rest of the body, it is important to think globally about maximizing the health of the body in order to maximize neurological function in multiple sclerosis. And in fact, if you look at the consequence of having more than one health problem, you can see, wrong button here. You can see that they actually sum. So if you have hypertension and, elevated cholesterol or heart disease, that increases your risk, almost doubles it. If you have 4 diagnoses, it can increase it by a factor of 300%. So these are big effects. These are as large effects as we often see in medicine today. Also, you're going to hear later on the benefits of exercise, and I'm not going to go into this in depth, but just to point out that almost everything in MS over time improves with exercise. And the biological basis for that is related to brain biology and how the brain responds to exercise and rewires and creates new pathways that improves function. Let me just go on back. There's one aspect here that you may not be familiar with, and that's self-efficacy. And so exercise not only improves a lot of these other symptoms, but it also improves your sense of control over this disease. Self-efficacy is a measure of how much you feel you can actually impact the course of your life by your own activities. This is a new data that none of my colleagues have seen. This is a collaborative project that I have with Dr. Carolyn Schwartz for many years, and we've been looking at the effect of having neuronal reserve, or improving neuronal reserve in patients and the impact on disability. And this is what's called a Mercator plot. What we're looking at is results from a questionnaire that asks patients about how much MS problems in these various areas impact their ability to do daily activities. So it's a major handicap. And we're looking at pain, mobility, hand function, vision, fatigue, cognition, bladder symptoms, sensory and spasticity. And then what we're doing is we're taking and stratifying patients into different groups. And this is based on activity. And by activity, what we mean is basically the amount of time that you're out of the house. Exercising, going to the theater, going to the stores, taking vacations, visiting with family. It's just having an active lifestyle. And we're looking at the impact of that on disability. And what you can see from this is that low passive and high passive refer to whether in the past you've done a lot to improve the neuronal reserve or cognitive reserve that you have, and that's through exercise and education. So if you've had a lot of exercise and education in the past, how often they go out of the house to go shopping or take trips or exercise, etc. And the point of this is that if you look at patients who in the past have been very active and are currently very active, they're this inner line right here. And the point of this Mercator map is that if you're really very healthy and have no symptoms, you're the dot in the middle. So the smaller the area inside this circle, the healthier and the more functional patients are. What you can see is that even if in the past you have not been very active, but you're active now, that actually improves you. That's the blue line. And that gives you more benefit than if you were active in the past and not active now. So being physically active during the disease, just getting up and doing things on a day-to-day basis substantially decreases the amount of disability and handicap that people have from MS, and you're going to hear more about that later in the talks. So I'm going to focus now on the disease-modifying agents. Again, these are agents that treat the inflammatory phase of the disease and try to prevent injury to the nervous system. So please keep in mind, there are actually no consensus about how to approach the use of these agents in MS patients today. So what you're going to be hearing are my opinions based on my understanding of the data. And I'm more than happy to discuss this with both my colleagues and you as to why I have ranked things the way that I have. But in fact, we have a tremendous amount of data. And it's not simple data. It's relatively complex, but you can use it to make informed decisions about the best options for an individual patient. Now, one thing to keep in mind is what our therapeutic goals are. My goal in treating MS is not to slow the progression of the disease. My goal in treating MS is to try to stop any further damage to the brain, to achieve what we call a disease activity-free state, and also to help use these therapies, if possible, to help reverse certain symptoms of MS, particularly fatigue, depression, and cognitive problems, but also improve mobility, less pain, and other symptoms over time. And that is now becoming possible for the first time in the history of MS with these therapies. So, when you're selecting an immunological therapy for a patient, there's a series of things that you need to do. First, we have to make sure the diagnosis is correct. This is not a small matter. It is not uncommon for patients to be given a diagnosis of MS when they don't have it. It's also not uncommon for people not to have a diagnosis of MS when they have it. Second thing is that once we have the diagnosis confirmed, is to use as much information as we can gather to try to identify what the risk of developing further disability is for the individual patient. And we do that by talking with you, finding out how previous attacks have affected you, what kind of function you have now, how long you've had the disease. We also, though, do it by looking at the neurological exam, but most importantly, by looking at the MRI. The MRI is actually the most informative test that we have to tell us what your risk of long-term disability is. Third, we have to know what other kind of health problems that you might have because they can interact with the therapies that we use, and I'll come back to that. Fourth, now and in the future, we will increasingly use other tests to determine how well you're likely to respond to a certain therapy or if you carry a higher risk with a certain therapy. We have one biomarker now, and that is a blood test to see whether you carry a virus called JC virus, which has implications for the use of Tysabri and certain other therapies. In the future, I think we'll have several other biomarkers that may be available. And then fifth, once we have that information, then we need to select an agent that we think gives you the best risk-benefit opportunity from the use of that therapy. And finally, we need to continue to evaluate you and be ready to change our minds or change therapies if, in fact, we're not getting optimal treatment response. Now, the risk categories for me are basically just three. I can't really tell what's going to happen to any individual patient. All I can do is to calculate probabilities of outcomes. It's like going to Las Vegas. You don't know whether you're going to win or not, but you can calculate the odds. So, for me, there's the low-risk category. These are patients that have what we used to call benign MS. They have very little evidence of injury in the nervous system by MRI, by physical exam, and by history. They have a mild form of MS, and in these patients, oftentimes, the disease will not ultimately end up fundamentally changing their life in any significant way. And as a result, they may not achieve significant benefit considering the risks and costs of the therapies that we currently have. And so some of these patients, we will discuss the options with them, and one option is not to treat, but rather to monitor them closely by MRI and regular visits, probably on an annual basis. However, that's only 10% of the population.